Right. Let's get back into it. We are picking up on slide 108. This is going to be the third part, and it should be third and final part for this this giant antimicrobial PowerPoint presentation. So here's a list of the other protein synthesis inhibitors. First off, we have chloramphenicol. As far as the kinetics are concerned, don't stress too much about this slide. This is just more of FYI. They do make a few different preparations of this. They have IV and IM. You'll notice here that it is excreted in the urine, but you do not need to worry about the dosing adjustments for renal impairment. So it's interesting to note there. And then you also do not need to worry about the dosing adjustments for hepatic impairment as well. Take-home point for mechanism of action, it inhibits the 50S ribosome. So that's kind of take-home point with that. Uses. So this one, you'll note here that it's usually not first line. I'm not going to say 100% of the time, but for the most part, you're not going to jump to this first line. You'll notice the cost-benefit analysis or the benefits versus risk analysis that you should perform, and make sure you are prescribing it when you have, quote-unquote, a serious infection. So this is something like you might see with a cystic fibrosis patient, bacterial meningitis maybe, and caused by some of these bugs here. But again, usually it's going to be something that is not first line, and part of it is, or the big part is because there's going to be less toxic agents that are effective. So it's preferred to use those other agents with some of these. So again, reserve this really for serious infections and typically not first line therapy. So I haven't seen it prescribed a lot. It's still out there, and it's still on the shelves in pharmacies, and you'll see it some, but definitely not your first line go-to drug. So it's safe to then have this as just an alternative therapy. So you can highlight that it's an alternative drug. And here's the reason why. Lots of adverse effects you have to think about. It is a more toxic antimicrobial. So first, you'll notice listed the aplastic anemia. It is idiosyncratic, so it's something that's quote unquote unpredictable, and it's one of those rare but serious side effects. And then related to that, there is a US box warning, so definitely add this to the slide, for blood dyscrasias. So there's serious and fatal blood dyscrasias, including aplastic anemia, also hypoplastic anemia, thrombocytopenia, and granulocytopenia. That they can happen after the administration of this antibiotic. So, and again, it's idiosyncratic and can be life-threatening. So again, a big reason why it's not a first-line antibiotic. It also has the rare but serious adverse effect when it's given to infants. It can cause a gray baby syndrome, which again is rare but serious adverse effects that's caused in newborn infants, especially if a baby is premature. So again, not first line. And then you definitely want to, if there is, for whatever reason, you have to give it, it's definitely something you want to be thinking about, the gray baby syndrome. And then you want to be monitoring the blood levels, etc. But because of these two things here, these two rare but serious adverse effects, again, not first line, and you have to think about toxicity when you're thinking about this medication. So take home point with this drug, never first line, or rarely, unless all the other kind of conventional treatments that are less toxic cannot be given. So for example, with Rocky Mountain Spotted Fever, doxycycline would be your first line, and then for whatever reason, if you couldn't do that, then you'd go to the chloramphenicol. But it would be something that, again, you'd have to be mindful of these adverse effects and then potential toxicities. So clindamycin. So it's used for aspiration pneumonia. You may see it for that. Bacterial infections, bacterial vaginosis. So, and they make special preparations for this. They make suppositories, vaginal cream, and special applicators. So this is a topical medication that we'll dispense in the pharmacy with a special applicator. Pelvic inflammatory disease too, which is actually given IM. And then you guys may have seen this, or if you have any experience with dermatology or anything, the dermatologist will prescribe this for severe acne. So they give it says here topical treatment of severe acne, which is true. But then sometimes too, they will give the PO, clindamycin. So by mouth clindamycin, depending on the severity of the acne. So you may see that too. Adverse effects. So severe diarrhea, definitely GI adverse effects. And then pseudomembranous colitis, definitely put a star by that. That is actually a U.S. box warning. So it's Clostridium difficile associated diarrhea. And so again, it's going to wipe out the healthy bacterial in your gut and then have an overgrowth of a C. diff. So again, when you're using clindamycin, especially PO or IV, so with your topical application, you don't have to be as concerned about these adverse effects. And so with the topical application, it's going to be more of localized, quote unquote, is what they call localized adverse effects. So it's wherever you apply it, you may have irritation to the skin, for example, would be an adverse effect you're more concerned about with clindamycin topically. But if you're giving it IV or PO, you definitely be thinking about the GI adverse effects and then specifically the colitis. And like I said, it's this Clostridium difficile associated diarrhea, and you'll see that sometimes abbreviated CDAD, CDAD, like see your dad. No, CDAD. So that is something that you have to be mindful of and think about. And overall, too, you will see, with clindamycin, just know that you will see it in a variety of different settings. You'll see it inpatient, outpatient, long-term use, short-term use. Just really, it's seen a lot. And usually well tolerated, but again, just remember that the C. diff with it. Linezolid. Mechanism of action, take-home point, again, binds to 50S ribosome. You guys hopefully start kind of noticing a pattern with my mechanism of actions. I try not to make them too complex for you guys, but definitely, memorize Linezolid is 50S ribosome. It is, depending on the microorganism, it's either bacteriostatic or bactericidal. Again, just FYI for me, from my testing purposes. Uses. So we talked earlier about how VRE is becoming an issue. So it is something that you may be seeing if someone has a vancomycin resistance. It can be used for VRE infections. You'll notice too that it could be used for MRSA or so non-hospital acquired strep pneumo or some strep aureus, including MRSA, and then also maybe some skin infections too. Usually the more severe skin infections, it's not going to typically be your first line skin infection antibiotic choice. And then community-acquired pneumonia, if you may also see that as well. Another thing with use too, just note that it does have some potential for some toxicity, so specifically hematologic and neurologic toxicities, which we'll get into a little bit more in the next slide. But because of that, it's typically not preferred to be used in infections that require prolonged therapy. So that's typically over 2 weeks or over 14 days. And so linezolid should be used more acutely. And it's typically reserved for drug-resistant organisms. So definitely, like I said, it's, potentially used for a lot of different things, but as far as what it's used out in practice and what it should kind of be saved for, because this is a bigger gun, so to speak, when it comes to you should really save it for the VRE and MRSA. So that's going to be something that you see it used for more, or rather, that is the recommendation as far as it should generally be reserved for the treatment of infections due to drug-resistant organisms, is what the literature says. And the other thing is the brand name is Zyvox. And the reason I mention that is because I hear that a lot more. It's ZYVOX. Zyvox is what you may hear more so out in practice. And so it has potentially use for a lot of different things, broad spectrum. But as far as when you guys are prescribing it, I would limit its use for the VRE and MRSA. Adverse effects, I mean, I talked about the couple, the hematologic and neurologic toxicities that you have to be concerned with these. But then also GI adverse effects. These are more common, less serious, just more kind of bothersome. The thrombocytopenia and neutropenia are those rare but serious ones, and again, with increased exposure, so greater than 2 weeks, this potential adverse effect goes up. Other interesting thing too is it does inhibit monoamine oxidase, which we'll talk about more in some of the other modules coming up, like in the psych module. So this is one that's you can basically have a really bad adverse reaction depending on what type of foods you eat. So if anything has tyramine containing foods, so like aged cheese, red wine, so just basically a lot of delicious foods, right? So let's say if someone had eaten some aged cheese while on this medication, and this will come up in other medications too, you can have a sudden and severe high blood pressure. So it's actually a hypertensive crisis that happens, or you can cause serotonin syndrome. So its inhibition of the MAO is a big deal. It also too can happen if someone ingests caffeine while taking this antibiotic. They can also have that severe high blood pressure, hypertensive crisis. Also beer too, which is, I don't know if anyone's a beer fan, but so yeah, red wine, beer, cheeses, caffeine, some cured meats, so some sausages, salamis. Also, if they're vegetarian too, fava or broad bean pods Marmite. I don't know, that's popular in Australia. I don't know if anyone in the class likes Marmite spread, and then some of the fermented products, so like sauerkraut too, soy sauce, so any Asian food fans or whatever, we eat a lot of soy sauce, and then other soybean based condiments. So a lot of different things. So this is definitely one that you'd have to make sure your patient knows if they are on this. Hopefully it's for a good reason, like I said, MRSA or VRE, and then definitely it's something to make the patient aware of, that they need to watch their diet. This is one of those where there are a lot of food interactions that you have to be concerned with. And in my opinion, a lot of delicious food. So, which, so I don't know how, if this was me, some of these foods here I eat almost every day, and then like caffeine, forget about it, right? Everybody's on caffeine. But yeah, a lot of these foods I enjoy pretty frequently. And then also related to its inhibition of monoamine oxidase is you also have to worry about a lot of drug interactions with this antibiotic too. So it's typically not a huge issue, the drug interactions. The food interactions are usually more of an issue just because people don't typically think of food interactions when you think of, but drug interactions, usually people are more diligent about looking for those. And then the other thing too is, like I said, it should usually be shorter term, so less than 2 weeks. And so the drug interactions can usually be monitored or be modified pretty easily, but definitely, again, food and drug interactions, put a note here on this slide that you need to remember with Linezolid. So this one is actually, the brand name is Sinercid, and this comes manufactured together. It's two different antimicrobials, and they both inhibit bacterial protein synthesis. And they both work on the 50S ribosomal subunit. So therefore disrupting protein synthesis. This one again is a bigger gun. It's should be reserved and used for the MRSA and VRE infections. So again, I'm not going to say it's never first line, because you will sometimes see it being used, but definitely for the more complicated infections, and then the more resistant. And this is interesting too, because the only FDA use, or the only labeled use, is for complicated skin and skin structure infections. But then you do see it for other things, off-label, like I mentioned before, the quote-unquote off-label, so you will see it for a lot of other things inpatient. But again, it's a bigger gun, usually prescribed by your specialist, usually when you're concerned about resistance, concerned about VRE, MRSA. So the bacteremia is off-label, endocarditis is off-label. So yeah, those things are off-label. But as far as what you'll see out in practice, I'm thinking, definitely you may see it for complicated skin and skin structure infections, but I feel like it's prescribed, when you're concerned about VRE and MRSA, kind of regardless of, so if you have bacteremia, for example, or endocarditis, it will maybe be used for that as well. Adverse effects, again, GI adverse effects you have to be concerned with here. This one's also one of those that when it's administered IV, you have to be worried about the local effects, so to speak. So local pain, local inflammation, edema, infusion site reaction. Those are all things that you have to be thinking about. The other one that's not on here too is muscle pain. So arthralgia, myalgia is something that is a more common adverse effect that patients may be complaining about. And that's a generalized muscle pain all over their body. So in addition to the local pain of where it's infused or where it's actually given, you have to also be concerned about just an overall myalgia. Interesting too, it also, another one to add here to this slide is the hepatic adverse reactions of hyperbilirubinemia. It can happen up to 35% of patients that are given this. And it's worth noting that you do not need to make dosing adjustments for hepatic impairment, even though it has a potential adverse effect for the hyperbilirubin. So no renal dosage adjustments and no hepatic dosing adjustments. But anyway, so I would add a couple more things to this slide. Drug interactions. So again, you have to, because of it, this is inhibitor of the CYP, the cytochrome P450 specific 3A4, so specifically it's the 3A4 subgroup. Because of the potent inhibition of that, definitely need to put a star by here. Think about drug interactions with this. So there's a big list. Here's a few here that you can go through. And warfarin too, I know you guys had the coagulation lecture. Definitely warfarin, you always need to be thinking about drug interactions. So put a star by that. Anytime you see warfarin, Coumadin, think drug and food interactions. But then this antibiotic, definitely want to think about drug interactions. You don't need to worry about food interactions with this antibiotic, but extensive, long list. Pay attention to these here, but don't feel like you need to go and look up all the drug interactions because it's extensive. There's a ton on there. Again, usually when people are sick and they need these antibiotics, it's not a huge deal. So if they're chronically on some medications, you typically will just, like let's say, for example, they're on a statin. Sorry about that. Fast and the Furious behind me out here outside in the parking lot, revving their engines. Sorry about that. But yeah, so drug interact. Oh, so what I was saying is if they're on a statin or they're on, which is a cholesterol-lowering medication, they're on that longer term, or they're on hydrocodone longer term for pain control, then you either adjust the dose, maybe lower the hydrocodone dose while they're on this antibiotic, or maybe discontinue them or maybe switch them to something else. So, or something like with cholesterol, maybe just go ahead and take them off of that. I know there's also some psych medications that, again, if the patient could handle being either lowered on their psych medication or maybe taken off of it for a few days, that may be something maybe a potential strategy. Telithromycin, this is a broad spectrum. Again, mechanism of action binds to 50S. Similar as far as what it can be used for is similar to the macrolides. So you can think of it as, kind of mentally lump it together. You may be seen used for upper and lower respiratory tract infections. However, it can cause severe hepatotoxicity. So that is something that you need to be mindful of. And as far as dosing goes, you may need to adjust the dose if they have renal impairment. So this is one that it's interesting. It causes hepatotoxicity, but then the dosing adjustments actually if they have renal impairment because of the way it's excreted and the way it's metabolized. So so this is one that you need to be thinking about. Dosage adjustments for renal impairment, but then it's also adverse effects can cause severe hepatotoxicity. The other thing too on here that there is a box warning, a U.S. box warning from the FDA on that it is contraindicated in patients with myasthenia gravis. And so unfortunately, if a person has myasthenia gravis and they're given this antibiotic, it can cause or lead to a fatal and life-threatening respiratory failure. So definitely something to not use in a patient that has myasthenia gravis, which isn't a really common it's not a super common disease, but again, for boards, questions, etc., it's just one of those things. Just please note this drug, myasthenia gravis, no bueno, no, it's not good. Yeah, because of the it can cause death, unfortunately. I'm going to try to say this right because there's this. So in Oklahoma, they would say Mupirocin, which is not the way you say that. But ever since then, that's the way I think of it because there was this patient that would always say that. So Mupirocin. Okay, not Mupirocin. Sorry, yeah. You're going to have patients like that. Like there was also with there's another patient with, instead of saying Coumadin, which is the brand name for warfarin, they said Coudamin. So sometimes I'll catch myself when I'm out in practice or when I'm in front of you guys. I'll say some of these names kind of crazy just because there was a patient that would say it all the time. And but anyway, so Mupirocin is the way you say it. But this one, again, basically inhibits ribosomal protein synthesis. This one you see a lot being used topically, so it can be used intranasally for MRSA. And then I see it prescribed a lot topically. So this patient I was talking about, she needed it topically. So she had her tubes of Mupirocin weren't lasting long enough was what her complaint was. So I called the PA or physician or whatever to see about refills or whatever, just to make sure she's supposed to still taking it, et cetera, et cetera. But anyway, so yeah, I typically find this being used for topical infection. And just FYI, the brand name of this is Bactroban. And the reason I mention that is because it's been in my experience, a lot of physicians just refer to it as its brand name, Bactroban. Even though it is generic, it comes generic. It's a lot cheaper now. But just FYI with that on the brand name. The other topical treatment here that's not listed is Impetigo. You may see it be used for that. They have an ointment. The Bactroban ointment may be prescribed for that as well. So here's some great tables. Definitely look at these, squint at the details, read them all. Look at all the drugs listed. And so I've had questions before from students like, well, there's something on here, this table, that's not on your other slides. So, do we still need to know it? Yes. Put a star by all these tables. I definitely want you guys to know it. Make sure you know all the drugs listed here, all the clinical applications, adverse effects, and contraindications. And so, like I said, even if it's not on one of my other slides, definitely I still will pull test questions from these tables. I like these tables. And to me, they're part of my slides. So when I say it comes from my slides, but every year there's at least, a handful of students, at least a few students that will miss test questions because it'll be an adverse effect I have listed here. And we'll be like, oh, I didn't look to see that there was photosensitivity here because it wasn't on another slide. But again, so I'm not trying to talk down to you guys or anything. I always feel bad every year when students miss test questions because they didn't read these charts. So again, just please look at these charts and make sure you read through them. Look at the contraindications. You notice hypersensitivity is there for all of them, which makes sense. You expect to see that, but then also make sure that you look at the specific ones too. So. And then, of course, anything that the other thing, too, with testing questions, sometimes I say things and I tell you to add them to the slides. Those are other things, too, that if I'm saying it, I don't necessarily write it. So there was, I talked about myasthenia gravis earlier with that other drug. It may not be listed on here, but again, that's something that's a contraindication that I want you guys to know. So, again, things I say during the lecture, things that are on the slides, definitely things that I tell you to pay attention to. I'm not just telling you to pay attention to random stuff. I'm trying to get you guys to get the kind of most bang for your buck, so to speak, with my lectures. So anyway, so hopefully that's clear. And hopefully this will be the first year where there's not a student who said, I missed that because it's on a table and not, yeah. So, and I always feel bad, but those students never make that same mistake again, I guess, is the good thing about it after that happens. But anyways. Antimetabolites. So here again, for my testing purposes, classify these drugs as antimetabolites. These basically called antimetabolites because they interfere with the metabolism of folic acid, which folic acid's really important. And refer back to pathophysiology and to your biology prereqs and stuff as far as why all the reasons folates are important. But anyways, basically, it's not good for the bacteria if you inhibit the metabolism of folic acid. Oh, and then for testing purposes, don't worry about, memorizing all the steps in this cascade. Same thing here. It's the same. You will notice the sulfonamides and trimethoprim. This is where they work specifically, so those will be relevant for their mechanism of actions. But again, I feel like that's like more of a thing that you do in biochem, or maybe in pathophys. I'm not sure what Dr. Fuki's going to test you guys on, but for my testing purposes, don't stress about that. And then definitely read through this. I think it'll help you with this module, but then also it talks a little bit about methotrexate as far as it's helping, it's anti-cancer. We'll see that later, but just go ahead and read through that. Sulfonamides. So like the previous slide showed you, they basically inhibit PABA, the p-aminobenzoic acid incorporation. This one, you'll see the sulfonamides used for UTIs. Adverse effects: acute hemolytic anemia and crystalluria. So that's where there's crystals in the urine. Again, for the class of sulfonamides, those are things you may need to be concerned with. The dynamics, mechanism of action, it basically, like I said too, it affects folic acid. So basic take-home point that it interferes with bacterial folic acid synthesis, and it therefore affects the growth of the bacteria. And like with a lot of antibiotic, or all the antimicrobials, resistance is an issue, unfortunately. And so again, just note that. You'll notice the theme here throughout my slides, hopefully. Resistance, something we always have to be mindful of. Uses, so here's some specific uses for their specific drugs here. So here's some uses of the sulfasoxazole. So please note those. One thing too is please note that this does end in an azole, which there are azole antifungals, but this is one of those sound-alike, look-alike drugs that they talked about in the pharmacy. But so this is not an antifungal. So definitely for your classification and everything later on, we'll talk about antifungals and we'll talk about the azoles. But this is one that definitely keep that separate. The other thing to note here is that this does come from the manufacturer. In combination with erythromycin, which we talked about earlier, which is a macrolide we had already gone over, but in combination it is called pediazole. So P-E-D-I-A-Z-O-L-E, and the reason I mention that it's a really popularly prescribed, and a lot of times people refer to it by their brand name. But the pediazole is used for the otitis media, so for ear infections. So a lot of pediatricians you'll see using this, or the pediazole, this plus the macrolide, the erythromycin, in combination. And then the narcodosis, I don't know if we've been over it already, but you can have a pulmonary or systemic infection by the nocardia microbes. So anyway, so it can be effective for that. Sulfadiazine. So you notice again for the Nocardia infections. So you'll notice here, this one is one that can be used for uncomplicated malaria. So you may see that. Definitely read through these, but also you sometimes, or it could be used for acute otitis media. And then the other thing is too, it can be used as an adjunct for meningitis. And as far as prophylactic use, it sometimes can be prophylactically prescribed for rheumatic fever. And this is another one too. It's not, because of its spelling, it is confused with some other drugs too. So just please keep these drugs straight when you're spelling them, etc. So this is definitely where a time where spelling comes into play. So this is sulfadiazine, but then there's also sulfasalazine, which is it's just a few letters off. So definitely don't get those mixed up, which we'll have a couple slides. There we go. Wait, no, that's the bad example. That's not the right thing. So sulfadiazine, do not confuse with sulfasalazine, which is Sulfasalazine. Those are ones that are confused, unfortunately. And that second drug I mentioned, we will talk about later in the GI module. So this is why I stress that classification, spelling, how you categorize things are important. Sulfacetamide. So this one they make an eye drop, so it can help with conjunctivitis. And then this is also a topical product that can help with some dermatological issues, so infections, but then also for acne vulgaris, so for acne, and then for scaling, dermatosis. So, and this is an antibiotic that they only make in a topical preparation or in a ophthalmic preparation. So this is one that you can't order, by mouth or IV or whatever. And yeah, so popular with dermatologists, but then outpatient family practice physicians too will prescribe this for some of the different topical issues patients have. And I don't have it listed here, but as far as adverse reactions go, you don't have to be too concerned with adverse reactions just because there's not a lot of systemic exposure and it's not really absorbed. But definitely you want to think about anytime with any dermatological application, you want to think about skin irritation, burning sensation of the skin, pruritus, which is itchiness, stinging of the skin, etc. So now we have the silver sulfadiazine, another topical preparation, and so this is one that you will see. Again, I see prescribed by dermatologists, but then also family practitioners. But this is definitely helps with the prevention and treatment of burns, so help with second and third degree burns. So this is an interesting one because it's an antimicrobial and it's still considered antibiotic, but then as far as its use is concerned, it is used for burns second and third degree, but then it's still categorized as an antibiotic. So now these are going to be class. So this is for the whole class of sulfonamides. I've had students be confused in the past and they think this is a continuation of silver sulfadiazine. But so these are adverse effects. If you want to write on top, this is adverse effects for the whole class of sulfonamides. So you have to be, unfortunately, concerned with rare but serious blood dyscrasias. So you guys can read through all of those. I already mentioned this already. And the other one that you need to be worried about and put a star by is a hypersensitivity reactions. So this is where people will say that they have a sulfa allergy, quote unquote. So a lot of the times the lay public, they will say they have a sulfur allergy, hard on the on the ending there, sulfur, but it's actually SULPHA, sulfa allergy. So when people say they have a sulfur allergy, I usually don't correct them. Like, oh, you mean sulfa? You mean you're allergic to sulfonamide? I just ask them, was it antibiotic related, or what happened exactly? Was it a hypersensitivity reaction? But the Stevens-Johnson syndrome, SJS, is the most severe form of that, and it's really bad. If you guys have some time, maybe go Google image search that, or if you've ever seen it out in practice, whatever, it's definitely probably have a really vivid mental image of it. But it's a very, very severe. Luckily, it's more on the rare end, but rare but serious adverse effects. So SJS, definitely make a note of that. And then just in general, the sulfonamides are another class of antibiotics that you want to be thinking about hypersensitivity reactions. So far, to go through the list again, we have the penicillins with hypersensitivity, and then related to that is the cephalosporins, and then now we're talking about the sulfonamides as being the big players. Also note, though, that, hypersensitivity for antibiotics is just something you have to think about with all antibiotics, but then again, for board questions, for practice, for my test questions, those three that you want to mention, that you want to specifically be able to recall, are penicillins, cross-sensitivity with cephalosporins, and then the sulfonamides. And then later on, we're going to talk about the sulfonamides again, or a sulfa allergy, quote unquote, when we talk about some of the other. There's other pharmacological agents that, because of their structure, their chemical structure, there's some cross sensitivity there. And then the kernicterus in infants, again, rare but serious. But this is basically, it's a bilirubin-induced brain dysfunction that can occur. Contraindications. So we have relative versus absolute, which I don't think I've gone over with you guys yet this year, but an absolute contraindication is something that you must avoid at all costs. So it's something that you definitely do not kind of play around with, so to speak. So an absolute contraindications you can think of, I usually put a big X up with my arms if I'm in front of you guys, but you just think of These are going to be things that you just do not give sulfonamides for. Relative contraindications are ones that it's contraindicated, but that it's going to be patient dependent. It's going to depend on the health and kind of overall well-being of the patient, and then it's something that you can monitor, something that you maybe lower the dose, manage the administration of it, maybe take them off of add other medications to kind of manage it, for example. But anyway, so that's the difference between a relative and absolute contraindication. So for testing purposes, I definitely want you guys to know the difference. And it is something that, and I'll mention this throughout the year, it's an absolute contraindication or it's a relative contraindication. So the absolute, again, it's more of a black and white, never give it. Where relative, you'll see it. You'll see it out in practice. People will be prescribing it. Or you may see it in combination with some of these disease states. And then definitely put a star by here. I already kind of hammered this point home, hopefully, but the sulfonamide hypersensitivity, definitely put a star there. Something you'll see on your board questions, something you'll see for my exams. And then just one other note too, real quick, the G6PD deficiency, I believe you guys will go over in pathophysiology, but just in case you don't, it's a glucose 6-phosphate dehydrogenase deficiency. So this is it's one of those rare but serious. It's a genetic disorder that is typically in males only. So it's rare, even more rare in females, but so usually in males. And this is a condition that affects red blood cells. And so basically, if there's a defect in this enzyme, then it causes the red blood cells to break down prematurely, which is called hemolysis. So unfortunately, and then with the sulfonamides, the hemolysis is actually more pronounced, and so that's why it's an absolute contraindication. So it basically causes the hemolytic anemia that these patients have to be even worse or be more pronounced, and so it can be life-threatening. So that's why it's an absolute contraindication. Trimethoprim. This is, again, it affects folic acid, but inhibits dihydrofolate reductase. Some different uses here. It's not prescribed a lot by itself. It's usually in combination with the sulfonamide, and we'll talk about that on the next slide a little bit. As far as adverse effects go, you can lump it in with the sulfonamides as far as very similar adverse effects of sulfonamides. But its uses there, UTIs, acne vulgaris are one. Sometimes you see for PCP, the pneumocystitis pneumonia. It's an off-label use, and then, like I said, off-label too for UTI. And then read through those uses as well. So here's a combination. This is trimethoprim plus the sulfamethoxazole. So abbreviated, sometimes you'll see a TMP-SMX, and this is the generic for Bactrim. So when I mentioned the brand name Bactrim here, so it's BACTRIM, and then Bactrim DS, which the DS stands for double strength and refers to the dosing, is because people typically just refer to this as Bactrim. So definitely out in practice rotations, for prescription writing purposes, etc. It's rare, very, very rare. And I'm actually I probably only pharmacist. I don't even know who. So I have seen this on prescriptions, TMP/SMX, but it's very rare for me to see this actually written out. Typically, people will put Bactrim and Bactrim DS or TMP/SMX DS, which is double strength. And that's typically how it's written. So this is definitely one that, so for testing purposes, know the generic, and you'll see the generic name on there. But for real life purposes, I guess, or for, when you're out on rotations and stuff, I want you guys to know what they're talking about when you hear Bactrim, because it is a very popular medication, very popularly prescribed. It's, like I said, in combination. And then too, as far as dosing goes, they historically, you didn't have to use a double strength, but now it's always double strength. So that's 800 milligrams over 160 milligrams. So it's 800 milligrams of the sulfamethoxazole, and then that's 160 milligrams of the trimethoprim. And the reason I mention that too is because that's what you prescribe when you prescribe Bactrim. You prescribe Bactrim DS, which is 800 over 160. And the reason I'm spending a little more time on it too, because it's a really popular, let's see if we have the uses here. Yeah, we have a whole bunch of uses here. But it's used for a lot of different things, IV and PO. It's used for acne, bacterial meningitis, bite wounds, animal wounds, brain abscess. It can help with MRSA if you're concerned about that. Some diabetic foot infections, you may see that as well. Osteomyelitis, that's due to MRSA. PCP, which is listed here. Prosthetic joint infections. So skin and soft tissue infections too are things you have to be concerned around. And then UTIs, definitely. You see this a lot, prescribed a lot for UTIs. This is also a medication. So speaking of UTIs, speaking of UTIs, it makes me think of older women, because the older women can be prone to those. So, and I worked for a year in the nursing home setting, and so saw a lot of UTIs there with older women, and older men too. But in general, older women. This is definitely a medication that is on the Beers criteria. So I talked about the Beers criteria before. So, and that's BEER. So beer, like you drink a beer. Beers criteria. If you guys look up that, it's potentially inappropriate medications to be used in older adults. They also have the stop-start criteria, which is STOPP/START, which is an abbreviation. But that's another good criteria to use for geriatric patients. But the reason I mention that is because you do have to make renal dosing adjustments for Bactrim if you are going to prescribe it for UTIs. However, it is okay to use in an elderly population. So the Nitrofurantoin, which is generic for macrobid, which we'll talk about later, is one that you should actually avoid use of in geriatric patients. And there's different reasons why, and we'll talk about it later. But so this is an instance where it's maybe recommended, or it maybe be better to use this in an older individual for UTI. And again, I'm basing that off of the Beers criteria, or basing off the stop-start criteria. It's not just how I feel about the drugs or whatever. But I know some students have gotten confused in the past because you still need to think about their kidneys when you're thinking about. But it's not as severe as with the Nitrofurantoin, or so with some of these other ones. So you do have to make renal dosage adjustments, but again, it can still be used in an elderly population. So hopefully that's clear for you guys. But and then you notice too, traveler's diarrhea, it's used here too for that, and a lot of different uses you guys can read through. Also for IV, a lot more uses here. Read through those, but so Bactrim is one that you will be seeing probably prescribed inpatient and outpatient. It's pretty ubiquitous. And as far as adverse effects go, for adverse reactions, just refer to the class for the sulfonamides and the trimethoprim. And you'll notice here we have some adverse effects here listed. So see, it says here just see sulfonamide. So but you'll notice a ton of treatments. There's a ton of uses here. So again, like I said before, put a star by this table. Make sure you look at it. Like clinical applications, adverse effects, contraindications. That's all good stuff. Okay, now we're going to talk about the Fluoroquinolones, which is another popular class of medications that you'll probably see prescribed a lot. These all inhibit DNA gyrase. I said GNA, sorry about dyslexia here. DNA gyrase. And you'll notice these all, again, I think students like this, or it should be easy for memorization, but they all end in the floxacin. So you notice there, they all have the FOLXAICIN. So and with that too, sometimes people will just refer to them by their so Cipro, they'll just say Cipro, ciprofloxacin. Moxie, they'll call it Moxie. Levofloxacin. So I've heard all those, but yeah, so hopefully it's easier class to memorize because they're all pretty similar. So these are another one that are going to have generations classification. So I definitely want you guys to pay attention to those and squint at the generations. But for take-home point, mechanism of action, they basically all interfere with bacteria DNA synthesis. So you can have that for all the mechanism of actions for all of the fluoroquinolones. So first generation, we have the norfloxacin, which is the generic name, so sometimes you'll hear people refer to as Norflox, which is the brand name of it. But this one has some activities against bacteria that cause UTIs. This one also, in addition to UTIs, can be used for pyelonephritis, also for community-acquired pneumonia. You may see it use that. It is one of two ones that you may hear referred to as being respiratory fluoroquinolones. So the norfloxacin and levofloxacin are ones that you may hear people talk about as, oh, these are respiratory fluoroquinolones. It can also be used for gonococcal infections and then gastroenteritis. But it's similar to, so this nalidixic acid is a precursor to it. So that's just kind of FYI historical perspective. Don't worry about that. Second generation. So here we have Cipro, which is the brand name for ciprofloxacin. Ofloxacin, which is the generic for the brand name is Floxacin. And again, the reason I'm mentioning this is because people refer to ciprofloxacin by its brand name Cipro, and then the ofloxacin people will call Floxin, F-O-L-X-I-N, Floxin. So this has pretty broad spectrum, so gram-negative and gram-positive. So, and then specifically on ciprofloxacin, it has the best gram-negative coverage of all the fluoroquinolones. So if you're really trying to hit gram-negative, you may want to pick the Cipro, again, if there's no contraindications or whatever. Also, something to note about Cipro, and my wife just saw this on our pediatric rotation, that it does have Pseudomonas coverage, so it could be a good strategy if you're looking for something outpatient by mouth. So they make, Cipro by mouth. You can get that outpatient. So if you're interested in the Pseudomonas coverage, it was a kid with cystic fibrosis, and they were suspecting Pseudomonas. So that's something that you can prescribe for. Cipro is not good for community-acquired pneumonia. So like I said, the norfloxacin and levofloxacin are the quote-unquote respiratory fluoroquinolones used for community-acquired pneumonia. But anyways, and then Cipro too, it can be used, like I mentioned too, for the other things that were with the norfloxacin, but to UTIs, pyelonephritis, things like that. And then the ofloxacin. The ofloxacin is a little bit different than Cipro, so a lot of things that similar spectrum, similar coverage. But then the ofloxacin can hit the community-acquired pneumonia, and then the ofloxacin can also be used for acute bacterial exacerbations of chronic bronchitis. Third generation, we have the levofloxacin, which is the generic name for Levaquin. So you hear Levaquin mentioned a lot there. And then gadifloxacin, which is Tequin, Tequin. Again, maybe hear that referred to out in practice. Overall, these have less activity against bacteria, gram-negative, but greater activity against some of the gram-positive cocci. So MRSA is one that these can be superior for. And then, like I mentioned earlier, levofloxacin can be used for community-acquired pneumonia, in addition to the UTI, pyelonephritis, gonococcal, and then the gastroenteritis. And then with the gadifloxacin, you can think of it like the ofloxacin as far as its coverage. So, yeah. Fourth generation, we have the gemifloxacin, actually, you can go ahead and scratch it out, or that's no longer available in the U.S. So it was at the time when this book was written, but it's no longer. Moxifloxacin is still available. So keep that one, definitely remember that one. The brand name of that one is Avelox, A-V-E-L-O-X. And these are some of the broadest spectrum fluoroquinolones. So again, gram-positive, gram-negative, anaerobic too, and then they also have atypical coverage. So again, broadest, so definitely note that, the Avelox, it's kind of the biggest gun there. It can hit, it does have some CNS penetration as well, which makes this unique. And then it can be used for intra-abdominal infections. So again, because of the anaerobic coverage, it can also be used, you will see it used topically, or they make ophthalmic preparations of the Avelox. So you may see it being used for that as well. Kinetics, this one is just mainly FYI, but they make oral preparations. Like I said, the Cipro, they make oral preparations as well. These are ones too that you do have to worry about the Sometimes there's drug interactions, drug or food interactions. So these are ones of the fluoroquinolones are ones in the pharmacy we tell people not to drink with milk, or to take with, calcium, different vitamins, and acids, etc., because the absorption can be affected by that. And then another drug interaction here is that is with probenecid. So the excretion of the fluoroquinolones is blocked by probenecid, which probenecid we'll talk about more later when we talk about gout. That's a gout medication basically, that will go more detail later. So with this drug interaction, so if a person they did happen to have gout or they were on probenecid and they're given the fluoroquinolones, it's not an absolute contraindication or anything. It's just basically you need to monitor the therapy because it can increase the levels of the fluoroquinolones, and so maybe don't dose as aggressively, or maybe a little bit lower dosing. But it's basically, like I said, it's one of those absolute. I mean, it's a relative interaction as far as you just need to monitor the therapy. So it's not like an absolute contraindication. Mechanism of actions, read through this, but like I said, it just basically inhibits DNA gyrase. Resistance, again, is a concern with antibiotics. This is just FYI, but just, again, know that for antimicrobials. Uses, I went through the uses a little bit more earlier, but this is an overview here, and then it has some specifics mentioned here. So for Cipro. Adverse effects. So definitely GI adverse effects, like with a lot of things, is something that you have to think about. So with interactions with other drugs, we talked already about the food interactions, so with calcium-containing medications and then also calcium-containing foods. So it's something that can decrease the absorption of the fluoroquinolones. So if you are taking maybe some supplements, something with iron or whatever, or calcium supplements, and then food is also another one. With theophylline and caffeine, the fluoroquinolones actually increase the levels of caffeine and theophylline, and so that's why it's recommended to not use caffeine while you're taking fluoroquinolones. And then theophylline's a seizure medication that it causes increased levels of theophylline, and they may actually lead to some toxicity or some adverse effects with theophylline. And we'll talk about theophylline later. We'll talk about theophylline later in the pulmonology module. It's an older asthma medication. It's not really popular, not really used that much, but there nonetheless. It can also, the fluoroquinolones also interfere with collagen synthesis. So it's definitely something you want to note here. Put a star by that. There's actually a US box warning that the fluoroquinolones are associated with disabling and potentially irreversible serious adverse reactions that may occur together, including tendinitis and tendon rupture, peripheral neuropathy, and CNS effects. So you're supposed to DC the fluoroquinolones immediately and avoid use of fluoroquinolones in patients who experience any of those serious adverse effects. And then also it should be avoided in pregnancy. It is a pregnancy category C, but it is something that they recommend to avoid in pregnancy. And this is just because there have been some animal reproduction studies that have showed adverse events. And then they do know that these fluoroquinolones do cross the placenta, and they have considerable concentrations that the fetus is exposed to. You also have to be concerned about the hepatotoxicity, so it can cause abnormal liver function tests. And then here, this is just more historical references. So this trovafloxacin was actually removed from the market because of its hepatotoxicity. So it had the worst hepatotoxicity of the fluoroquinolones. So you can go ahead and just put that there for historical purposes, or don't worry about memorizing that drug there. But the hepatotoxicity is definitely something you want to be worried about with the fluoroquinolones in general. So you definitely want to, if there's any signs of hepatitis, you want to discontinue the fluoroquinolones immediately. So those things would include abdominal tenderness, dark urine, jaundice, and pruritus. So that's something that, could be potential signs of hepatitis, and then would be a rationale to discontinue the fluoroquinolone. Also note here the seizure, they do lower the seizure threshold, so that's something to think about if a person is prone to seizures, etc. And then all fluoroquinolones or quinolones prolong the QT interval. So I know you guys haven't had EKG yet, or ECGs. You'll be getting that in cardiology, and I think it's the next module. But you'll have a special class on that. But basically, with EKGs, there's a QRS wave that you look at, and QRST. And so the QT interval is where you look at where the Q and the T are, and it basically, if it increases that interval or prolongs it, then you have an increased risk for altered cardiac conduction, which basically puts you in increased risk for arrhythmias. So anytime, so for pharmacists, we don't really mess with the EKGs and stuff, but we definitely are concerned about the QT interval and QT prolongation. And the reason why is because a lot of medications and then also drug interactions and stuff can cause QT prolongation. And can lead to arrhythmias. So the fluoroquinolones may prolong the QT interval. And so because of that, you need to avoid the use in patients with a history or at risk for QT prolongation, or if they have torsade de pointes, which is a type of arrhythmia, which we'll be learning about. If they have uncorrected hypokalemia, hypomagnesia, and because those also can lead to arrhythmias. And then if they have cardiac disease, so heart failure, MI, bradycardia, or if they're taking other medications. So if they're taking fluoroquinolones and they're taking another medication that can increase the QT interval, then that's something that also needs to be looked at, and maybe, again, maybe discontinue one of their other medications. So like, for example, when we are taught in the psychiatric module, we'll be talking about antipsychotics and antidepressants. Well, there's some antidepressants and antipsychotics that can increase the QT interval. And so those would be you probably need to discontinue them, or, be cautious if you're going to be prescribing a fluoroquinolone. Another box warning that's not on here is that there is a U.S. box warning for myasthenia gravis with fluoroquinolones. So the fluoroquinolones may exacerbate muscle weakness related to myasthenia gravis, and so you're supposed to avoid use in patients with a known history of myasthenia gravis. Unfortunately, there have been cases of severe exacerbations, including the need for ventilator support and death, when a person who has myasthenia gravis has been given fluoroquinolones. So that's another box warning, so please add that to this slide. The other thing to note too is that there was an FDA did a safety review in January 2017 on the fluoroquinolones, and again they basically strengthened their recommendation, in that because the fluoroquinolones have been associated with serious adverse effects, that they should be reserved for use in patients who have no alternative treatment options. For the following indications: acute exacerbation of chronic bronchitis, acute sinusitis, and acute uncomplicated cystitis. They can be used for things like UTI, uncomplicated UTI, but again, the FDA is strengthening their warnings. Like I said, they did the safety review in January 2017. So you still will probably see them being prescribed a lot, but I'm thinking because of this strengthening of their warning, that they may be not prescribed as much, and that it'll be interesting to see what happens in the future and what happens in the next couple years or so with these increased warnings. And then here we go. Here's a good summary table. Again, drugs here, you can cross that one out because that one's no longer available in the US. It was withdrawn because of hepatotoxicity. And then also cross out here the gemifloxacin. So here's nitrofurantoin. This one wasn't in the book I based my slides off of. So my slides are based off the rapid review of pharmacology, but for whatever reason, nitrofurantoin was missing. But I definitely want you guys to still know about this. It is a miscellaneous category as far as how it's categorized. The generic name is, the brand name is Macrobid. So you may hear that used a lot, or, I feel like that's usually what people refer to it as. So you'll notice its mechanism of action is kind of a grab bag here. So it binds and alters the bacterial ribosomal proteins, and then that inhibits protein synthesis, and finally affects the cell wall synthesis. You'll notice here its uses: UTI treatment and UTI prophylaxis. And here's the brand name, by the way. and some dosings. Just FYI on the dosings, don't worry about memorizing those. But like I mentioned earlier, so if you look at the Beers criteria and the stop-start criteria, this is considered an inappropriate medication for an elderly population. So typically, elderly is typically defined as being 65 years or older. You're supposed to avoid for long-term suppression, so definitely something you don't want to use for UTI prophylaxis in an elderly population, because and it specifically needs to be avoided in the elderly population has a creatinine clearance less than 60 mils per minute, and it has the potential for pulmonary toxicity, and so basically, again, it's recommended to be avoided in elderly population. But it could be something that you could use and could prescribe for a younger woman who has a UTI. And then here's just some more dosing. Just FYI, don't worry about stressing on memorizing that. I mentioned this too, geriatric. Okay, so I actually had it listed for you guys, but so yeah, avoid geriatric use. Definitely highlight that, star that. And then you don't have to worry about hepatic dosing adjustments, but however, it is contraindicated in patients with a previous history of jaundice or hepatic dysfunction. Use, a couple uses here. We talked about the UTIs already, and then acute cystitis it's a good for that as well. Adverse effects. So we have the common ones here listed here. So GI is one of the common ones. The rare but serious ones are listed here. So definitely read through those. But typically you have to worry about just GI adverse effects. Contraindications. You notice talking about the renal impairment here, and then also the hepatic impairment here, and then of course as everything, hypersensitivity. And then I'll let you guys just read through the rest of that. Kinetics and dynamics. Just read through this. Don't stress about memorizing this, but it's just there for your FYI. And that is the end of that presentation. So thank you all for your time and attention. Please email me directly if you have any questions about anything that we covered. So this is the last part, and we are done with this first antimicrobials presentation. So stay tuned for this next one. Let me open it up here, do a live demonstration. So we still have one other PowerPoint to go through. It's going to be the other antimicrobials. This is also a big presentation. You notice it's 100 slides, so I probably will chop this in half and do 2 parts to this one. So look forward, or maybe not look forward to it, but just be on the lookout for that. All right, I will talk to you guys later. Have a good one. Bye.